miscarriage. A miscarriage is defined as a pregnancy loss before 24 weeks of gestation. 24 weeks is considered the period of viability. An embryo or a fetus is considered to be viable beyond 23 weeks, 6 days in the UK. A recurrent miscarriage, however, there is limited consensus as to the definition. In the UK, according to the Royal College of Obstetricians and Gynecologists, a recurrent miscarriage is defined as 3 consecutive miscarriages, but according to the American Society of Reproductive Medicine, a recurrent miscarriage is defined as 2 consecutive miscarriages. Considering 3 consecutive miscarriages, the rate in the general population is about 1%, whereas if we consider 2 consecutive miscarriages, then the rate is about 5%. About 30% of women with recurrent miscarriages will probably have some delay and difficulty in conception, and about 20% of such women will probably have a second trimester miscarriage, a late miscarriage as well. 45% of women who have recurrent miscarriages have a live birth and a successful pregnancy before. However, 20% of them may have had a preterm delivery or a growth-restricted baby. There are various causes that have been confirmed or suspected as to the etiology or pathogenesis of recurrent miscarriages. But there are certain basic risk factors that are associated with recurrent miscarriages as well. And 3 common ones include maternal age, the number of previous recurrent miscarriages, and certain lifestyle factors. Maternal age, we know that over the last few decades, the age at first pregnancy has significantly increased, including many women having their first child after 35 years of age. The chance of having a miscarriage in a woman less than 25 years of age is around 11%, whereas the chance of having a miscarriage at 40 years of age is almost 40%. At 20 years of age, a woman who has had 2 consecutive miscarriages still has more than 90% chance of having a successful live birth. Second, we come to the number of previous recurrent miscarriages. A woman who has had 3 consecutive miscarriages, the chance of having a live birth in a subsequent pregnancy is about 75%, or within the next 5 years rather, is about 75%. Whereas a woman who has had 6 consecutive miscarriages, the chance of having a live birth within the next 5 years is only about 50%. A woman who has had 3 consecutive miscarriages, there is nearly a 45% chance of having a miscarriage in the next pregnancy. Among lifestyle factors, obesity has been found in observational studies to be an independent risk factor associated with miscarriages. Regular and high intake of alcohol and smoking, including passive smoking and excessive caffeine, have been considered to be associated. However, any lifestyle modification has not had a significant effect on improvement in the outcome so far. Now we'll discuss the definitive and the suspected causes of recurrent miscarriages. Unfortunately, about 50 to 70% of women with recurrent miscarriages being investigated, we do not find a cause, which is obviously frustrating, not just for the patient but for the clinicians as well. There are other factors like anxiety and psychological stress that is often associated with recurrent miscarriage that may have an impact by altering the endocrinological and possibly immunological mechanisms as well, but we do not have any convincing evidence how or why it affects. Among causes that have been found to be associated and confirmed to cause recurrent miscarriage are chromosomal or genetic abnormalities. About 10% of recurrent miscarriage, between 5 to 15% rather, are associated with chromosomal or genetic abnormalities. It is thought that almost 30% of all embryos only make it to have a successful pregnancy or a live birth. 30% of embryos actually die or do not make it around the time of implantation. Another 30% is lost before 6 weeks of gestation, and 10% are lost after 6 weeks of pregnancy. The commonest cause for such abnormalities include segregation of chromosomes during cell division, and trisomies are the commonest, but there could be monosomies and triploidies. Among translocations of chromosomes, both reciprocal and Robertsonian translocations are associated with an increased risk of miscarriages and recurrent miscarriages. Reciprocal translocations, there is no loss of genetic material, and therefore most often the carrier is phenotypically normal. However, in their gametes, there is a 50 to 70% chance of having an unbalanced translocation, and 70% of them, of such individuals, when one of the couple has the translocation, there's a 70% chance of a miscarriage, and even where there is a successful birth, there is a higher chance of multiple congenital malformations, mental abnormalities, and therefore genetic counseling should be offered. Robertsonian translocations include a centric fusion of acrocentric chromosomes and with the loss of the short arm. There is a 3 to 6% risk of recurrent miscarriages in women with translocations, both Robertsonian and reciprocal. The second cause that we come to is thrombophilia. We know that pregnancy itself is a hypercoagulable state, which means there's an increased risk of clots formation and thrombosis. And this is actually nature's protective mechanism to protect women at the time of childbirth from heavy bleeding. However, certain conditions called thrombophilias further increase the risk of clot formation, and with pregnancy loss and pregnancy problems including severe preeclampsia and growth restriction. There are two types mainly. One is called acquired thrombophilia, and among acquired thrombophilia are also called antiphospholipid syndrome or Hughes syndrome. 15% of recurrent miscarriages, so women with recurrent miscarriage, there is a 15% possibility of having antiphospholipid syndrome, as opposed to only 2% in low risk obstetric population. Women who have antiphospholipid syndrome, if untreated, there is only a 10% chance of having a successful live birth. It is thought of that with antiphospholipid syndrome, there could be inflammation, abnormal testicularization, particularly the extrapillary trophoblasts functioning, and increased microthrombi in the placenta and in the placental bed. Antiphospholipid syndrome is the commonest and most important treatable cause of recurrent miscarriage. To diagnose antiphospholipid syndrome, there has to be one clinical and one laboratory findings. Among clinical findings could include a thrombosis, either arterial, venous or capillary, or a pregnancy problem, which could be either a miscarriage, 3 consecutive miscarriages before 10 weeks, 1 miscarriage after 10 weeks, or at least 1 preterm delivery from severe preeclampsia or growth restriction due to placental insufficiency before 34 weeks of gestation. Among the clinical and among the laboratory features, it could be either anticardiolipin antibody IgG or IgM in medium to high titers on 2 occasions 12 weeks apart, lupus anticoagulant on 2 occasions 12 weeks apart, or anti-beta-2 glycoprotein 1 antibodies on 2 occasions 12 weeks apart when one is not pregnant or within 6 weeks of pregnancy. Now, apart from acquired thrombophilias or antiphospholipid syndrome, we have inherited or hereditary thrombophilias. However, hereditary or inherited thrombophilias are more common with second trimester miscarriages. They include activated protein C resistance, which is due to factor V Leiden mutation. This is due to mutations in the genes. There could be prothrombin gene mutation, which is factor 2 problem. There could be deficiencies, protein C deficiency, protein S deficiency, or antithrombin 3 deficiency. Also, methylene tetrahydrofolate reductase, which is associated with hyperhomocystinemia, has also been considered, but there is no convincing evidence that they are associated with recurrent miscarriages. Congenital and other abnormalities, structural abnormalities of the uterus and the cervix have often been implicated for recurrent miscarriage. Congenital abnormalities of the uterus are much more common in women with recurrent miscarriages, particularly with second trimester miscarriages. In the general population, the incidence is estimated to be between 2 to 16%, but women with recurrent miscarriage, the incidence can be up to 37%. Fibroids are a little more complex. Their association with recurrent miscarriages is about 8%. Submucous fibroids and intramural fibroids that distort the endometrial cavity and large intramural fibroids have been associated with the implantation problem, but with recurrent miscarriage it's not very clear. However, an observational study did suggest that removal of submucous fibroids that distorts the cavity does increase the pregnancy rate and live birth rate and decreases second trimester miscarriages. Asherman syndrome, which is intrauterine adhesions or scarring resulting from previous infections or intrauterine surgeries. Their association with recurrent miscarriage is about 10%, and they may affect or cause miscarriage by fibrosis, by local inflammation, or by reducing the volume of the uterine cavity. However, there is no convincing evidence or direct evidence regarding this. Cervical incompetence is often associated mostly with second trimester miscarriage, but there is no definitive test to diagnose it pre-pregnancy. Endometrial causes. Next we come to endometrial causes. Endometrial causes, it's been well known that the decidualizing stromal cells of the endometrium acts as sensors to allow good quality embryos to implant. So any problem with decidualization may be implicated with miscarriages and recurrent miscarriages. Also, a problem with decidualization may increase the window of implantation and thereby allowing more poorer quality embryos to implant. However, these are all from in vitro animal studies, and at present there is no definitive test to diagnose these. Next we come to endocrine problems. We know that uncontrolled diabetes mellitus is associated with miscarriages and congenital abnormalities, and therefore good control of diabetes pre-pregnancy is important. Hypothyroidism has often been implicated. However, there is no convincing evidence that either overt hypothyroidism or subclinical hypothyroidism causes miscarriages or recurrent miscarriages. But there is an increased demand of thyroid hormone, and subclinical hypothyroidism is thought to induce overt hypothyroidism in pregnancy because of the increased demand. Thyroid peroxidase antibodies has been associated with recurrent miscarriages, but there is no definitive evidence as yet. Prolactin is known to affect the hypothalamo-pituitary ovarian axis and negatively affect folliculogenesis, oocyte maturation, and luteal phase defect. But the treatment with bromocriptine or cabergoline and its benefit or direct association with miscarriages is controversial. And lastly, among the endocrine problems, we come to polycystic ovarian syndrome. Polycystic ovarian syndrome, or PCOS, is the commonest reproductive endocrine problem in the reproductive age group. PCOS is definitely associated with miscarriages, but the exact mechanism is controversial. It could be due to hyperandrogenism, insulin resistance, and hyperinsulinemia. Obesity itself is an independent risk factor also. Hyperandrogenism, or increased androgen in the follicular phase, is found in 11% of PCOS patients with recurrent miscarriages. Insulin resistance is found in 17 to 27% of PCOS patients with recurrent miscarriages, and insulin resistance is thought to affect implantation by suppressing the circulating levels of glycodelin and IGF-BP1. Hyperinsulinemia has not been directly implicated, or there is no evidence with recurrent miscarriage. Next, we come to infections. Initially, in the earlier studies, infections, particularly the TORCH infections, that is Toxoplasma, Rubella, cytomegalovirus, and herpes, and also Listeria and bacterial vaginosis had been implicated with recurrent miscarriage. However, there is no definitive evidence, and therefore no treatment as such is directly warranted at the moment. And lastly, we come to immunological factors. Again, the fetus and the placenta that contains paternal or the father's genes, it in itself is a mystery how the maternal body modulates the immune system, maternal immune system modulates to accept and tolerate the semi-allogenic foreign antigens in the fetus, the placenta. It is thought, this tolerance is thought to be mediated through MHC proteins, decidual leukocytes, and cytokines. HLA class 1b alleles and polymorphisms have been found to suppress maternal immune activity, but their role with recurrent miscarriage is controversial. Uterine natural killer cells are the most common decidual leukocytes found, and they are a rich source of cytokines and growth factors. They are thought to be important in decidualization, vascularization, and immune tolerance, but their density does not change or have not been found to change significantly in women with recurrent miscarriages. Peripheral natural killer cells are completely functionally and structurally different from uterine natural killer cells and have no role in recurrent miscarriage diagnosis. And finally, male factors, sperm DNA damage or fragmentation have been thought to be associated with recurrent miscarriage. However, as of today, we do not have any definitive evidence on that. So in summary, miscarriages, and including recurrent miscarriages, is somewhat common. There are some causes that can be treated, or alternatives like IVF and pre-implantation genetic testing in cases of chromosomal or genetic abnormalities can be offered. Thrombophilia can be treated with Clexane and with anticoagulation, blood thinning medications and aspirin possibly. And a few other endocrine abnormalities may be treated, or congenital abnormalities may be treated with surgery. But there is unfortunately still 50 to 70% of recurrent miscarriages we do not find a cause. However, thankfully, most women with recurrent miscarriages still has a fair chance of achieving a normal live birth with or without intervention. Thank you again.